Hi, guys, and welcome to another episode with Dr. Suresh. We are talking today about statins and cholesterol again. Now, I recently did a video covering one of Dr. Annette Bosworth's, Dr. Boz's videos, all about statins and cholesterol and the truth about them and what keto and carnivore doctors are not telling you about cholesterol and statins. Make sure you guys watch that video. I'll put a link at the end of the video because it is an important one to watch in conjunction with this one today. This one, we are looking at a episode from Joe Rogan and his interview with Dr. Aseem Malholtra that happened a little while ago. Dr. Aseem Malholtra is a very famous UK-based cardiologist who is quite famously against the overprescription of statins in particular, but really all medications. Now, he has some other outspoken views on things like COVID vaccines, which we are not going to discuss in today's episode. That is for another time. Basically, Dr. Aseem Malholtra campaigns against the overprescription of statins. And in his opinion, he thinks that they are very widely overprescribed. And we are going to talk a little bit about this in this episode today. Of course, I'm going to be giving you my commentary and hopefully providing some of the studies that he is talking about, showing you the actual data and so on. So let's get into the episode.
The Joe Rogan Experience.
Can you please tell us, what is the mechanism? How do statins work, and what does it do to lower cholesterol?
Yeah. So for many years, there's been this misconception that high cholesterol is one of the most important risk factors for development of heart disease.
Which it's not. It is a big risk factor. Well, it's a risk factor, I should say, but it's not the biggest risk factor. It's not even that big necessarily of a risk factor, and it's certainly not the biggest. There are other much bigger risk factors out there. For example, type 2 diabetes is about 10 times at risk of cardiovascular disease. Even things like a raised homocysteine can raise your baseline risk by about 5 or 6 times, depending on your level of homocysteine. And yet almost no doctors actually routinely check this. I do, pretty much all my patients, but a lot of doctors don't routinely check this, which is a bit of a travesty. Anyway, we're getting slightly off topic. I'm digressing. We'll get back to the video.
So I broke down the data and I've published a lot on this stuff to look at it properly. And Joe, this the association of cholesterol and heart disease came from something called the Framingham study, which was in Massachusetts, started in 1948.
Yeah, massive study. It's been running for decades.
Carried on for several decades.
But there are criticisms with it.
Where they followed up 5,000 people, and many risk factors for heart disease came from that correlations, which were then validated, like things like type 2 diabetes and high blood pressure, even smoking, and high cholesterol. Now, what's interesting about Framingham is when you look at the associations of total cholesterol and heart disease, it was only there when your total cholesterol, the significant association was only there if it was over 300 milligrams per deciliter.
Which is in Australian units or UK units, it's around 7.7 millimoles per litre for cholesterol. When you're doing a conversion from milligrams per deciliter into millimoles per litre, you need to actually know what you're converting. It's not just a straight like 10 times or 15 times, something like that. Or it's a division of 10 to 15, because it depends what you're actually looking at. So for glucose, it'll be slightly different. For triglycerides, it can be slightly different again. For things like testosterone, I mean, it changes basically. So best to use a calculator for these kinds of things. But yeah, 300 milligrams per deciliter is around about 7.7 millimoles per liter.
Very few people have total cholesterol that high. And we have to also understand that most of your cholesterol is genetic. 80% of your cholesterol is genetic.
Yeah, I mean, my total cholesterol, I think, is about 6.5. So yeah, it's getting up there. But I don't mind that. I'm happy with that. But just gives you an idea.
80%.
80%. Because cholesterol is a really important molecule in the body. It's not just it's important for maintaining cell membranes. It's an important role in the immune system. Hormones, vitamin D synthesis, all of that stuff, right?
Which we spoke about in my video covering Dr. Boz's video. Cell signaling, immune function, cellular repair, cellular walls, hormone production, vitamin D production, all of these things require cholesterol.
Right.
So we really should think carefully about how just jacking it down to obscenely low levels, which is what some people advocate for. Obscenely low levels, which may actually increase the risk, paradoxically. If you look at things like the ARIC study, which basically a big study shows very low levels of LDL cholesterol actually have a slightly higher risk of cardiovascular disease and certainly a higher risk of all-cause mortality, which really is the ultimate endpoint. If you are more likely to die from the intervention, regardless of really what else happens, it is basically a bad intervention. And yeah, that's just all I need to say on that one, really.
So it's genetic. You can alter it with your diet, the components of it, something called triglycerides and HDL, so-called good cholesterol, right?
Yeah, you can definitely modify those with your diet for sure. But total cholesterol, LDL, don't necessarily overly change that much. Though, interestingly, this development of, kind of so-called lean mass hyper-responders, quote unquote, they often do, I mean, my cholesterol, actually, I wouldn't say I'm a lean mass hyper-responder necessarily, but my cholesterol, total cholesterol, LDL, did go up quite significantly when I went off my kind of standard American, standard Western diet and onto a, basically very keto/carnivore diet. My cholesterol basically doubled. Now, I don't mind that. I'm happy with that. My risk is still very, very low. But it's just something of note that it can actually change with diet.
But so the total cholesterol was not a very good indicator. So if it was very, very
interesting thought tidbit there, though, it's quite funny. Before, when I did my blood test before, the labs never commented on my blood tests, saying that there was any issues or whatsoever with my blood tests. But then when I went on to carnivore, really, really heavy keto carnivore, my results started coming back quite high. Suddenly then the lab was commenting on things like, oh, this patient must have familial hypercholesterolemia. But I never had any problems before. So it's just a funny tidbit, basically. It doesn't really mean anything, but it just shows you can't always trust what these labs are reporting, what they're saying. And you should look at the actual numbers, not just the summaries.
High, there was association, but what's interesting about that is almost all of those people had a genetic condition which gave them very, very high levels of cholesterol. It's called familial hyperlipidemia.
So basically what he's saying there is the real association with very high cholesterol was associated in people who have a genetically really high level of cholesterol, this so-called familial hyperlipidemia or hypercholesterolemia. Now, I don't think I have that myself personally because my levels were perfectly fine before I went on the carnivore. So it's very unlikely that I have that. But we can't deny that having an extremely high level of cholesterol is quite a strong risk factor potentially for development of cardiovascular disease. And he's not saying it's not.
Affects 1 in 250 people, right? And then at the very other end from Framingham, the very low levels of cholesterol, less than 150 milligrams per deciliter or 4 millimoles in European terminology, there was almost no heart disease. So again, there's genetic factors there.
And lower than that might increase the risk. Look at the ARIC study.
So basically, people with genetically low cholesterol tend to not develop premature heart disease.
Premature. Not just heart disease, but premature heart disease. And that's the key thing there.
Another interesting caveat, most of that data on the development of heart disease was only up to people who are 50 or 60. And what wasn't publicized is that once you hit 50, as your cholesterol dropped in Framingham, your mortality rate increased.
Which we've seen. So what he's saying there is in Framingham, over 50 years old, what they didn't report really is as your cholesterol goes down, your all-cause mortality risk goes up. Now, that's not saying that statins are increasing your mortality risk, and mortality, of course, meaning dying, a risk of death. He's not saying, and Framingham study is not showing that statins increase your risk of death. No, but purely on the cholesterol perspective, lowering your cholesterol for the sake of lowering cholesterol, if you're over the age of 50, if you look at the Framingham data by itself, and this has been repeated a number of times, it potentially is going to increase your risk of death. Now, if you look at trials like the Sydney Diet Heart Trial and the Minnesota Coronary Trial, even the LA Veterans Trial, though that did have a lot of criticisms about it, they basically showed the same thing. Initial publications basically said, oh, cholesterol is really bad. But subsequent reanalysis and actually properly looking at the data when it was actually kind of unlocked and extracted and so on, allowed people to look at it properly. And they said, oh, that's interesting. As cholesterol goes down, all-cause mortality goes up. So you're at risk of dying more with a very low cholesterol. That is very interesting. According to these 3, possibly 4 big studies. Isn't that very interesting? Now, that's not saying that statins increase your risk of death, no, but it's saying that a very low cholesterol might increase your all-cause mortality. And it doesn't matter if you don't have a heart attack, but then you die from something else. What's the benefit? The ultimate benefit is all-cause mortality. That is the ultimate endpoint. And if we're not winning, what are we even doing here? Why are we giving statins to people if it's not improving that? That's the question.
Never really discussed. So I looked at all of this. Oh, that's interesting. But I think the thing that really sort of was a nail in the coffin for me in understanding the association of cholesterol and heart disease was very weak, was William Castelli, who was one of the co-directors of Framingham, cardiologist, in 1996, did a full summary of Framingham. And he said this. He said, unless you're, because, you're going to talk about, you may be thinking, oh, okay, hold on, there's good cholesterol and bad cholesterol. So he specifically focused on what we call LDL, bad cholesterol.
Quote unquote bad cholesterol. There isn't a good, there isn't a bad particularly, but you can certainly get damaged LDL cholesterol, which is very bad, oxidized or glycated LDL, that's small, dense LDL. That's a big problem.
And he said, unless your LDL cholesterol is above 7.8 millimoles per liter, which is something like, Joe, it's probably at least 300, pretty much.
Yeah, it's 300, as we said earlier. So 7.7 millimoles per liter goes back to, you can't actually quite see it on the screen there, but it's 300 basically.
Around 300 milligrams per deciliter. It has no value in isolation in predicting heart disease. So what they determined from Framingham was your risk of heart disease as one of the risk factors was your total cholesterol divided by your HDL, the good cholesterol, the ratio. So
okay, can I just interject there a little bit? That's entirely right, but it just annoys me when people say H. It's meant to be pronounced H, A-I-T-C-H, not H-A-I-T-C-H. Just annoys me.
So that's the first thing. So the association of cholesterol and heart disease is quite weak, first and foremost.
It is weak.
Second question is, when you try and prove that there is a biomarker that is causal in heart disease, you want to show that if you lower it, then there is a difference in heart attacks and strokes, for example.
And they've tried many times to show this. There is a ton of studies looking at this, repeatedly trying to show that lowering cholesterol, basically lowers your risk of heart disease. Yes, but more than that cholesterol is causative for heart disease. And do you know how many studies there are demonstrating that cholesterol causes heart disease? 0. Absolute 0. 0 studies ever showing that cholesterol causes heart disease. Now, there's an association, absolutely, but association can be prone to all sorts of biases. Association is not very good when it comes to research. And you can't draw cause and effect. There have been 0, absolute 0 studies ever showing that cholesterol causes heart disease. Even when you look at the totality of the evidence, there are still basically no studies which convincingly show that cholesterol might even cause heart disease.
And only in 2019, more recently, I co-authored a paper in BMJ Evidence-Based Medicine with 2 other cardiologists.
And BMJ is a big, internationally renowned journal. You don't get into the BMJ for no reason. Like I can't just write some whatever crap and get it into the BMJ. It's a peer-reviewed, prestigious publication that you have to know your shit to get into.
And what we did was we looked at all the drug trials at lowering cholesterol.
And there's a lot.
Find out, is this true? When you look at it in totality, not cherry-picked evidence, is there a correlation with lowering LDL cholesterol and total cholesterol and preventing heart attacks and strokes? And this is based upon randomized control trial data. So this is the most robust evidence you can get.
So randomized control trials, if you're not sure what that is, basically is pretty much the gold standard of clinical trials. And what you have is you can have it, single blinded or double blinded or not blinded at all. So randomized control trial basically is you've got to select certain, number of patients in or participants in your trial. The more the better, generally speaking. You have to do calculations to work out the adequate power, so you can actually draw significance. But generally speaking, more patients, more study participants equals better results. You're not going to get great results from 1 or 2 people. You want 1 or 2,000, generally at least where you can. So that aside, randomized control trials, you take those group of people and you say, right, half of you are going to get intervention A and half of you are going to get intervention B. Now, intervention A in this case might be statins. Intervention B would be a placebo. So the people, or maybe something else. In a blinded trial, one of those people involved, so to speak, are going to be blinded from what they're taking. So usually that would be the patient. So that would be a single blinded trial. So the doctors and so on, the researchers know what the patients are being prescribed, what they're getting. The participants, though, do not. So they'll get the statin and they'll get the placebo. And so they don't know. There's no real then effect. Well, I'm taking the statin, so I'll do something different and whatever else. So you kind of get around that. The really gold standard is the double blinded. So the researchers, the doctors also do not know what the patients, what the study participants are getting. And that way, again, you can ensure there's really no interference. There's no bias thrown in. The doctors aren't dropping hints or anything like that, or acting in a different way towards people, because they don't even know who's getting what either. And that is really the gold standard. So that double-blinded randomized control trial, that is the gold standard of research. Commonly, though, people think that meta-analyses or systematic reviews are the gold standard. That's not actually true. What a meta-analysis and systematic review is basically looking at lots of different studies and then putting them all together. People think this is better because they're just more studies, more data must be better. I've already told you the more people you have, the better it is. Yes, but they're only as good as the studies that go into them. And we are going to come to this later on. So it is a really important point. Systematic reviews and meta-analyses are only as good as the data that goes into them, the trials that go into them. Basically, garbage in equals garbage out. Remember that.
Joe, no clear correlation. It was BS. The whole thing was BS in that sense.
Sorry, just to recap there, because I went off on a bit of a tangent there, but it is important. What he's saying here is there is no correlation between between low cholesterol, between high cholesterol and the causation of cardiovascular disease. 0 studies have ever shown that, and they've tried.
It's very weak, if anything. So that means, then the next question is, well, hold on, how do statins work? And that's the question you asked me earlier.
Exactly. How do statins work? If lowering cholesterol doesn't really do that much, why are we even prescribing people statins?
It's a great question.
This is where you should think about watching next. Watch this whole video, but next, watch my video that I cover from Dr. Boz on statins and cholesterol, what keto doctors don't tell you.
It's a really important one. Statins do have a small benefit, but one of the properties of statins, which isn't talked about, is they have anti-inflammatory and anti-clotting benefits.
Which is most likely the biggest benefit from statins, not the cholesterol lowering. Interestingly, the inflammation, the anti-inflammation and the anti-thrombotic properties of statins are for the most part not dose dependent. So just being on a low dose of a statin is likely to give you a lot of benefit if you are a very high risk individual. If you're not, you probably shouldn't be on them, in my opinion. That's not medical advice. That's just general advice, my own opinion. But the side effects of statins, and of course the cholesterol lowering properties of statins, are actually dose dependent. So again, should we be jacking people up at all costs onto the highest dose tolerable? And that, again, we'll come back to with side effects. Or should we just say, you know what, just go on a low dose of a statin and you're going to get the majority of the benefits and less of the risks and the side effects, of which there are many.
So even though they lower LDL cholesterol, the real benefit in preventing heart attacks and strokes is through that mechanism. But when you break it down, as I said before, your risk is, the benefits are about 1% if you're low risk of heart disease. But if you've had a heart attack And many patients I see have had heart attacks and they get automatically put on statins.
That is standard therapy. And I get a lot of patients coming into me saying, you know, doc, I've just had a heart attack and I want to stop my statin. I want to go carnivore, keto, whatever. And it's like, okay, let's actually have a conversation around statins, around your risks as an individual, and whether they would benefit you or not. More often than not, I'm actually advising them to carry it on, but maybe at a lower dose, perhaps.
And the cardiologists rarely even check their cholesterol, because in the cardiology community, we kind of knew that. It was like, it doesn't matter what your cholesterol is, let's put them on a statin, because the trials show there are benefits. But
which leads to a lot of the complaints around cardiologists from patients I hear saying that all they're really doing is just putting me on the statin. Like, why am I even going to them? And I do sometimes wonder.
Those benefits,
they're not really offering any other interventions.
You break them down in absolute terms. This is really crucial and important. And this isn't cherry pick stuff. This is what all the evidence shows, and it's been peer reviewed, etc. If you've had a heart attack, patient comes to me, doc, shall I carry on this statin, or I've been put on this statin, or I'm getting side effects? I say to them, listen, let me just explain to you the benefits first, so that you don't have an exaggerated fear of stopping your statin.
Really important. People are so worried about statins. They want to get off them at all costs. Often, I think, to the detriment of themselves. They're willing to vastly increase their risks just to not be on the statin because of their worry about what may happen down the line, rather than just seeing if they actually have any issues in the first place, and then actually looking at the benefits versus the risks. They've kind of just people have become very blinded in the sense that they're just absolutely, just totally against statins. They won't even have a conversation around them.
And you also don't go around with the illusion of protection thinking that's the only thing I need to do now.
Yeah, I see that a lot as well, unfortunately. Patients get put onto statins and then they just think, you know what? I'm fine. I'm not going to have heart disease now. I'm not going to have a heart attack. I'm on that medication. I'm on the statin. I'm all good. I don't need to worry now. I can eat my KFC and my Maccas and my fries and my soda and my alcohol, and I can smoke and I can drink and I can have diabetes. Who the hell cares? I'm on the tablet. It's all good. Oh no, wait, I'm having a heart attack. Oh crap. Maybe I should have not done that. It definitely happens.
Over a 5-year period, if you take your statin religiously and don't get side effects, right? Because remember, the trials took out people with side effects. So best case scenario.
They did. They definitely did. This is a huge criticism of statin manufacturers, the drug companies, and the people that run these trials. So what Dr. Aseem Malholtra here is saying is, and there is very good evidence, we know this is very true. Basically, this isn't even to suggest this. We know this is true. A lot of the trials that have been looking at the side effects of statins took out patients who had side effects from the statins. So what that means is they excluded, sorry if you can hear anything in the background, my kids are watching TV downstairs. They excluded patients who had side effects. And then they basically said, right, okay, let's give you an example. So let's take 100 patients, right? And 99% have side effects. I'm just going to make something up, okay? So they're left with one patient out of that 100. So 1% of patients did not have a side effect. And then they ran the study. And then that patient did not have any side effects. That one patient from 100 did not have any side effects. And then lo and behold, 100% of patients tolerated statins. 0% had any side effects. But is that actually true? Well, no, it's not, because they excluded 99% in the first place. And the actual headline would be 1% do not have any side effects. 99% were not tolerated. But that's not what the studies are showing. So I've pulled up a couple of studies here that he doesn't reference, but some of the ones that he might be talking about. So this is from the Prosper trial. Let me see. Hopefully you guys can kind of see this. And it's, Prosper trial. And basically, I'm not going to go through these in detail. You guys can look these up. I'm just going to show you so you can look all of these up. But basically, this Prosper trial, they excluded a lot of the people that had side effects, basically saying that it was really well tolerated when in fact it actually wasn't. There's another one here, the CTT trial, so cholesterol treatments trialists. I'm sorry if a little bit is maybe off the page. Let me kind of bring it in a little bit here. And basically, again, it doesn't actually really say in this article, but you guys can look this up anyway. This is the reference here. You guys can look it up, of course. And basically what they did was, this was a meta-analysis. So I said earlier I was going to come back to this meta-analysis and systematic review. So they looked at a meta-analysis, 170,000 people, big study in 26 randomized control trials. Now that might sound on the surface amazing. This is, oh my God, this is like robust data. This is serious, hardcore data. 170,000 people over 26 good quality, supposedly randomized control trials. That's pretty epic in terms of the number of people and the amount of data points and so on. But the majority of the trials that they used for this CTT meta-analysis, they did a run-in period before the trial. Now, how the hell they get away with this ethically, I have absolutely no idea. But they did exactly what I said they did in the example. They took all those patients, gave them statins for 6 weeks. All of the people who had side effects were excluded. And then everybody else, they put into the trial. And then lo and behold, statins are one of the best tolerated medications ever to be produced, to be prescribed. Well, yes, that's what happens when you exclude everybody who has side effects. That is a bit of a problem. Dr. Malholtra, I think, says a little bit later that about 50% of people do not tolerate statins. I think it's actually slightly higher than that, but it's probably around the ballpark. If you look at the drug companies, they say they're one of the best tolerated medications on the market. But if you speak to doctors at the coalface, things like people like GPs like myself who are prescribing these medications, the vast majority of people do not want to take them, and they do not tolerate them terribly well. I mentioned in the other video I did, my mum, who was visiting over from the UK, she's now left. Hopefully she's landed safely. She's probably still in flight, actually. It takes a long time to get back to the UK from Australia. She was put onto statins and she got terrible muscle pain, terrible leg pain. And then she stopped it and it went away. And she started it again and it came back. And so she stopped it again and it went away. Almost certainly the statins are causing her that muscle pain. Now, also, she probably doesn't even benefit from those statins. She's got a bit of risk, but she's not terribly high risk. She's got no atherosclerosis as far as a coronary artery calcium score. She has had a stress echo, which was perfectly normal. She's had carotid artery Doppler, I think, which is also normal as well. Her blood pressure, she is on tablets, but it is controlled. She hasn't got diabetes, etc. She does have a family history, though. So she's going to go and have a CT angiogram. And if that's clear, then all good news. Hopefully it will be for her. I'm sure it will be. But she was just prescribed a statin simply because she ticked a box with her GP. Now, that's another story again, but she's a good example of just really an over prescription of statins, not thinking about the patient in front of you.
Your benefit of a statin is 1 in 83 for saving your life.
Yeah, so the number needed to treat, which is the number of medications you need to give somebody, number of people you need to treat, with that medication or that intervention, in this case a statin, to give benefit, is around about 350. So you need to treat about 350 people actually to really get that much of a benefit. Dr. Malholtra is saying 80 odd. I'm not sure where his stats come from. But if you Google thennt.com, that's a good website for looking at these kinds of things. The number needed to harm, which is the number of people you need to treat with an intervention to cause harm, significant harm. I'm not talking about a little bit of side effects, muscle pain, etc., but big side effects. In this case, diabetes is about 1 in 250. So you're more likely to develop type 2 diabetes than you are to prevent a non-fatal heart attack. But the biggest risk factor for heart disease is type 2 diabetes. Yet we're more likely to give people that on a statin.
Right? And 1 in 39 in preventing a further heart attack. Now, a lot of people find that quite underwhelming. Another way of looking at the statistics, Joe, and this is important for populations, looking at those trials. And what I'm about to tell you, when I talk at conferences to doctors and general practitioners, and there's like a gasp from the audience, right?
This is true. When I say this to patients, they they don't even know what to say. They are just absolutely gobsmacked. I'll let him finish, and then I'll comment.
When I tell them this, and this is published in the BMJ. So in the randomized trials, you look at an average. How much? Well, if I ask you that question, right? You've had a heart attack, let's say, for example, and statins are one of the most prescribed drugs, are the miracle cure, whatever, one of the most potent beneficial drugs in the history of medicine. If you take those,
they're a $1 trillion industry.
If you take a statin for 5 years, having had a heart attack, in that 5-year period, how much would you think or hope it would add to your life expectancy? You've literally survived a heart attack, right? And now you've been given this pill, which your doctor's telling you you must never stop. This is going to save your life. How much would you hope it would add to your life expectancy over a 5-year period? Over that period, we can incrementally.
25%, 30%.
I'm laughing because I know the answer here.
30%.
Yeah. Okay. So a few years. I'll add a few years extra. Yeah. You want the answer?
Yes.
Just over 4 days.
3 to 4 days. Yeah. That's the average benefit of being on a statin. 3 to 4 days of increased life expectancy. 3 to 4 days.
4 days.
4 days.
Maybe those are great days, though.
Well, no, fair enough. Absolutely. And,
Yeah.
but this is so, and the reason I'm mentioning that is when you look back over the last few decades and people talk about what has driven down death rates from heart disease, there's this assumption it's been the mass prescription of statins. Millions of people are taking statins. But the evidence suggests there's a separate analysis done. They looked in European countries, high risk and low risk people of heart disease over 12 years. Was there a reduction in heart disease death rates because of statins? And the answer was no. And that doesn't mean that the data is fraudulent. It's been misrepresented. But which
is very, very common in the research and medical world. Data is not necessarily fraudulent and not lies, but very much misrepresentation or exaggeration or under kind of exaggeration, whatever the word is there, deliberately kind of downplaying the evidence as well. Things like Sydney Diet Heart Trial, Minnesota Coronary, deliberately downplayed to basically obfuscate and hide the evidence.
Except, say it's a 4-day increase, right? But these are in people who didn't get side effects who were adherent to statins. And real world data tells us, Joe, even people who've had heart attacks, maybe 50% of them will stop taking it just within a few years, mainly because of side effects. You can understand.
Yeah, I think it's probably around that figure, 50%. It's probably about right. It's pretty actually overwhelmingly one of the worst tolerated medications out there. With no doubt. Just ask any GP, any doctor that prescribes statins. It's one of the most untolerated medications out there.
And why that hasn't had an impact on the population. But think about that. This is one of the most powerful, lucrative drugs in the history of medicine. And this is how marginal, let's be polite here, how marginal the benefits are.
Now, once this information...
Yeah, 4 days, 3 to 4 days on average. But these are a $1 trillion industry. This is a big, big deal for drug companies to be pushing these medications onto doctors, onto patients.
Has been out there and it's been published and you've had these talks and people are aware of this. What has been the reaction? And has there been any change in how it's prescribed?
Generally, I think the answer is no. There is very little change, though recent Australian guidelines are strongly suggesting that we check things like coronary artery calcium scores to assist with the deprescribing of statins, which is actually really amazing. There's even movement on that front is incredible. I often say to my patients, medicine and research, medications, etc., they're like an oil tanker. There's so much inertia just constantly pushing it forwards in that same direction. Even if you do make an about turn, it might just take a very, very long time to actually filter through and make any significant differences.
So after this publication, the BMJ initially, and then I had to get another job, right? So I lost that job in that hospital. I then ended up working for free briefly in another NHS hospital, Cardiologist.
It sounds like people like Gary Taubes, Professor Tim Noakes, These people who basically just got, tried to do low carb, keto, all this stuff, and basically got punished, got penalized, got kicked off their training programs and all these kinds of things for basically speaking out. Unfortunately, the UK particularly has a bit of a bad record, when it comes to these kind of things like Bristol Heart Baby scandal, these kind of issues where there just was a lot of cover-ups, a lot of political things and just so much agenda in the background and so on that, yeah, you can get into real trouble if you're starting to criticize, the powers that be, basically, in this case, drugs and drug companies, and in this particular case, statins.
Department that I worked for free, doing 1 day a week. Because I had another role with health policy, which I'll come on to, that they were paying me some money and I didn't want to stop seeing patients. So I was working for free in one hospital for a year in a cardiology department. In sort of March 2014, I got a phone call, in fact, an email initially from the editor of the British Medical Journal. And she said, Aseem, let's have a meeting. I think I went to meet her and she said, there is a man called Professor Sir Rory Collins. Professor Rory Collins is probably considered in the world the lead statin researcher. He was at Oxford University. He got his knighthood from the Queen because of his work on statins. He has said that you need to retract Abramson and Malhotra's papers because there is a significant error on the side effect issue, and this is going to cause harm. People are going to stop their statins.
And yeah, let me make that clear. If you get a paper published and then you have to retract it, it pretty much just completely destroys your credibility. And as far as research and so on, that's pretty much almost your career over. And that's a really, really big deal, potentially more than having to work for free or not having a job for a little while. That is almost a career-ending move. And you don't want to be waking up in the middle of the night with an email from the editor of the BMJ. That's not what you want.
And she said straight away, no, I'm not going to retract it, but we're very happy if you would like to publish it, send a critique in and we'll publish it. But for some reason, he decided he didn't want to do that. So this back and forth was going on. And then out of the blue, he decides, whether it was him or somebody else, to go to the Guardian newspaper. And I get a phone call.
Hey, that's not what you want either. You don't want newspapers ringing you up for comment either.
From the Guardian and the BBC, which again was headline news, that what Abramson and Malhotra had done, it became a news story, front page of the Guardian, was so damaging in terms of their error on the statin side effects issue that people will die, essentially. This is almost as bad as they were trying to make parallels with Andrew Wakefield and the whole measles, mumps, rubella issue that happened many, many years ago. That was the scientist that lost his license because he linked the MMR vaccine to autism, right?
Yeah, Andrew Wakefield is an extremely wealthy individual now. Not that that should make anyone want to do that kind of behavior, but yeah, big scandal. He basically admitted that he faked it all, made it all up, lied about it. Was never any evidence that MMR vaccines were linked with autism whatsoever. And he lost his license to practice, and he now lives in America and is married to Elle Macpherson, I believe it is. So he's done pretty well for himself, despite all of that. But again, like, you're getting these kind of comparisons in the news and so on. Like, this is pretty much almost career-ending, kind of stuff. This is pretty serious stuff for speaking out against the overprescription of statins.
So they were trying to create that kind of frenzy, and I'm like, whoa, this is okay. So I went on BBC and I stood my ground, and that, I think, put the BMJ under pressure. And then the next thing that happens is, I remember I was with my cousin in New York. I'll never forget this. And I get an email, a press release from the BMJ, which I knew was going to, and this is, to be honest, it's an attack on one's credibility. But the BMJ then decided they were going to send our articles for an independent review, whether or not they should be retracted. And Joe, just to put things in context here, that's potentially career destroying, in the sense that if my article got retracted, it got so much publicity, and I genuinely believe what I said was correct, but it gets retracted, then your credibility is undermined pretty much forever. And your career's, it would be career destroying for me. I'm at the beginning of my career. So I was on trial essentially for 2 months.
Yeah, and that's not what you want. And I apologize if you guys can see my family in the background. This is what happens when you record at home when you've got 4 kids. That's life. You just get on with it. It's fine. It's not a problem. This is the thing. This is like potentially career ending. You're being compared to people like Andrew Wakefield. You're basically being, the media is telling everyone that you're killing people, that you're harming people, you're causing people harm. As a doctor, the kind of oath of Geneva, or as people often, kind of erroneously refer to it as the Hippocratic Oath. We haven't taken the Hippocratic Oath in a very, very long time. I took the Oath of Geneva. Don't ask me to recount it. I can't remember it at all. But it's basically the same thing, first do no harm and all the rest of it, of course. So when you're being said that you're doing harm to people and so on, this is a really big deal. This is a really big problem,
if you like. And, it was tough. It was very, very tough. There was a panel, they convened, they asked me to, send in responses and then whatever else. I didn't know what was going to happen. And then I think it was August 2014. I remember it broke the news, and it was, I got an email, and basically the panel had come back 6-0 unanimous in our favor.
Wow.
Amazing. And the thing is the default most likely, and all that mounting pressure, the default probably would have been to retract. And so they have to kind of go against that default because there's so much inertia pushing for statins and lowering cholesterol. So to get a 6-0 unanimous decision is absolutely incredible. And it shows you the research that he did and the truth, basically, that statins are most likely very often over prescribed. And I've said this repeatedly on my main channel on YouTube, on my social media, and to my patients face-to-face in consultations.
Oh.
There was no call for retraction because John Abramson went through a lot during that period as well. I know you interviewed him.
Yes.
And we talked and whatever else. When that happened, Joe, there were two things that I could have done. One was, wow, this is like too much. I don't think I can handle this. I'm just going to, I'm going to hide away and just keep a low profile.
Which is probably what I would have done. I don't think I'm thick-skinned enough to weather something like that, going on national news and being told, that you're harming people and, this kind of thing. And look, you got to have a slightly thick skin to get onto YouTube. I learned that, early on. I had a YouTube channel, really for 4 or 5 years now, my other channel. And at the start, it was all fine. I just did some basic videos. And then one kind of took off a little bit and people started commenting saying that I was a shill for drug companies and all this kind of thing. And it really bothered me. It really affected me. And I pretty much just shut it down straight away. And then it took me another couple of years to go back to it. I wish I hadn't, now, but I did. I'm better now. I'm a bit thicker skinned now with a bit more experience and so on. A bit more sure of myself, a bit more knowledgeable about what I'm doing research wise and so on. But I don't think I would have been able to weather that. Pretty brave man for all of that. Pretty brave.
But I thought, no, you know what?
But I mean, it's people like him, people like Professor Tim Noakes, Gary Taubes, these kind of people who have suffered in the name of trying to right these kinds of wrongs, that has allowed people like me now to come onto social media and to start to talk about the things that I talk about as well. So all the credit really goes to these guys that have preceded me.
Well, this is about ethical evidence-based medical practice.
Of course, people like Gary Fettke as well, orthopedic surgeon in Australia, who again, basically same kind of thing, was basically criticized very heavily, went through 2 years, I think, of investigation, suspended by APRA under pressure from the basically dietitians, the Australian Dietetic Society, I think it was, basically pushed by the Coca-Cola Company and Sugar Research Foundation and various associated affiliations there with sugar companies, basically because he was campaigning against sugar.
There were some corrections that needed to be done, some caveats.
Sounds so dystopian and, 1984, but this is exactly what happens. This is real life, unfortunately.
That they added into the papers around the side effects issue. So I carried on this campaign. I carried on publishing in other journals, kept talking about transparent communication, ethical evidence-based medicine, statin over prescription. There are other things we can be doing in terms of lifestyle, right, which are going to be more powerful.
Way more powerful than statin prescriptions.
Whether it's low-carb Mediterranean diet, exercise. Why are we not focusing our attention there, Rob?
Mediterranean diet is kind of mostly garbage. French diet, definitely. Yeah, very, very good. Things like Danish, Scandinavian, this so-called Scandinavian paradox is really, really important to look at as well. But Mediterranean diet is, if you look at the books, Big Fat Surprise by Nina Teicholz, I think I have a copy over here somewhere. Yeah, so here, Big Fat Surprise by Nina Teicholz. Absolutely amazing book. And my son has come back to join us again. Absolutely amazing book. And in it, she talks to, I literally just opened the page on the Mediterranean diet. So I don't know if you can see there, it says a test of the real Mediterranean diet, just to show you. I do have that book. Excellent book. The Mediterranean diet is, I mean, for the most part, it's actually a scam. Really anyway, and it was kind of monetized and sold and all the rest of it, all these things that happen, unfortunately. People mean well to start out and then it just gets bastardized and so on. But anyway, I'll get back to the video.
And just giving people all these pills that they think is going to protect them from heart attacks, and in most cases it doesn't. And in that journey, and this went on for a few years, this is where things got really interesting. So there was, to answer your question, yes, there was a lot of backlash. It was tough. There was a bit of smearing going on. But I
A bit sounds like a lot. Jesus.
realized then, as a public health advocate, that you've got to have a thick skin and grow a rhinoceros hide. And those are the words from a man called Simon Chapman. Simon Chapman is a professor of psychology in Australia. He was considered the lead campaigner in making sure there was tobacco control in Australia. And he wrote a paper talking about his 38-year career in public health advocacy and gave 10 lessons. And one of those lessons is this: as soon as your work threatens an industry or an ideological cabal, you will be attacked, sometimes unrelentingly and viciously. So grow a rhinoceros hide. And I thought, you know what, I'm up for it.
Yeah, I have a thick skin, but I don't think I have a rhino hide. I'm not sure I could have gone through all that personally.
I'm up for it. So many more people came out of the woodwork to support me. Other doctors said, you're right, and I thought.
And he is right, 100%.
This is about truth and transparency and about ethical medicine and highlighting all the corruption and the conflicts of interest. One of the things that Professor Collins hadn't been made apparent is his department had taken over £200 million at Oxford for doing research into statins from the drug industry. And they also kept the data commercially confidential.
Which means nobody can access it. Nobody else can scrutinize it. Nobody else can fact check it. And all they have to go on is the say-so of these researchers, who are incidentally heavily sponsored, basically, by the drug companies. What is the likelihood that they're going to be 100% factual and accurate in their data? If they're refusing to release data, if they're sponsored to the tune of $200 million and basically don't have a job if they don't appease the drug companies, what's the likelihood that they're going to be factual? What's the likelihood they're going to be critical of statins if that is what the data shows, which is what Dr. Malholtra is suggesting it shows, and quite frankly, it does show that. Probably not a very high probability.
So most of the publications and guidelines that were coming on statins were emanating from that department where no one had been able to independently verify the data. And he is quoted in The Guardian saying, only problematic side effects from statins affect 1 in 10,000 people.
Which is bullshit. Absolute bullshit. It is so poorly tolerated as a medication.
So I thought this doesn't add up. I think these are biases, conflicts of interest. I'm not saying that he was deliberately malicious, but I think there's a huge, conflict of interest there that is clouding his judgment. Plus, he's not a clinician; he doesn't see patients. So there's all of those things that I think limit his ability to really look at the evidence properly.
And that's the end of the video. And I have a big issue as well there with people, with doctors on YouTube and so on, influencers who don't see patients, who don't, again, actually have that kind of real world feedback, that real world data. They're talking about these things, but not actually taking any responsibility. Things like cholesterol, statins, all of this kind of stuff. They're providing false narratives, in my opinion. But that is an aside. What this video is hopefully kind of illustrated to you guys is statins most likely are very, very overprescribed. We've got a cardiologist talking about it here, saying that, statins are very likely very, very overprescribed, very poorly tolerated on the whole. And a lot of the information around statins has been hidden, has been obfuscated, has been misleading and misrepresented. Probably not lies, outright lies, but certainly misrepresentation, suppression of key information, over exaggeration of the potential benefit, and very much a downplaying of the side effects and the tolerability issues with statins. Statins remain useful for the right individual, the right person at the right time for the right problem. My opinion, though, statins are far too widely prescribed. I think they are vastly overprescribed. I think they cause people a lot of problems. And I personally stop statins far more than I start them. Thank you guys for watching. I'll see you in the next video.